Bismillahirrahmanirrahim. Welcome to ERA. I am Dr. Muhammad Talat, Assistant Professor of Radiology, Cairo University. First, I would like to invite you all to interact with me, either with like, dislike, write any comments, positive, negative. Don't worry. Write any comments. It will help me to modify my way in teaching, and by the end, it will be more beneficial for you. We have this case today, an elderly patient presented by sudden loss of conscious level. As we have here, we have a large intracerebral hematoma, and this hematoma is localized at the left basal ganglia region and extends superiorly to the centrum semioval. And this hematoma is irregular in shape, hyperdense, so we have acute hematoma. And this hematoma exerts mass effect in the form of compression of the left lateral ventricle, this one. And we have also midline shift to the contralateral side by 1.2 centimeter. This line connects the foramen row towards the midline. Also, this hematoma exerts mass effect in the form of effacement of the cortical sulci. Look for the cortical sulci here. On the left side, it's totally effaced as compared to the contralateral side. So this is the mass effect of the hematoma. We should also measure the hematoma itself. It measures about 6.6 times 5.5 times 6 centimeter in the craniocodal dimension. As we said before, the 3 dimensions should be multiplied by 0.52 to get the volume. And the volume here, in this case, about 113 cc. According to the guidelines, if we have hematoma more than 50 cc, it is indicated for surgical interference. So this one indicated for surgical interference. Before reporting this case, hold your phone and inform the neurosurgeon by the time. We need also to add some of the most important findings, that we have also extension of the intracerebral hematoma into the ventricular system. This one inside the compressed ventricular system. So we have here intraventricular hemorrhage. Look for this one. Is occipital holes, fluid levels with gravitated hemorrhagic blood content. Also, we have here inside the third ventricle extension of the hemorrhage, also inside the aqueduct of Silvis, and also the intraventricular system extends to the fourth ventricle. So this is secondary intraventricular hemorrhage. It's not primary because it is an extension from the intracerebral hematoma. We have also here in the axial plane effacement of the basal cistern here. It's totally effaced, the ambient cistern. This one is suspicious for transtentorial descending transtentorial brain herniation. Please revise our previous video for the brain herniation, because this one is highly suspicious for brain herniation. Let us go to see the coronal plane. Look for this one. Look here. At the right side, the basal cistern is preserved, while on the left side, it is partially effaced by the herniated brain tissue. This is the central brain herniation. It is a form of the descending transtentorial brain herniation. So we have suspicious of brain herniation across the left tentorial cerebelli. We have a suspicious of brain herniation, one of the red flags. So we are dealing with acute intracerebral hematoma. We need also to think what is the underlying cause for this one. Once we have intracerebral hematoma, we should search for the underlying cause. If we are dealing with traumatic patient, trauma can lead to intracerebral hematoma and the brain contusion. And the brain contusion is a mix between cerebral edema, hypodense cerebral edema, and hyperdense hemorrhagic component. So this one is post-traumatic. Once we have non-traumatic patient, we should think either primary or secondary. Primary, we can call it spontaneous causes for intracerebral hematoma. we should think for two main causes, hypertensive or cerebral amyloid angiopathy. Both of these causes are commonly present in elderly patients. Hypertensive hemorrhage most commonly present or located at the basic ganglia and the brainstem. Cerebral amyloid angiopathy most commonly located at the periphery. Subcortical intracerebral hematoma most commonly. We have also secondary causes for intracerebral hematoma. Vascular malformation, for example, AVM, and this one of the most common causes in young patients. So the message here, once we have intracerebral hematoma in a young adult patient, we should follow up this hematoma after resolution of the hematoma to see the underlying cause. Maybe underlying AVM, maybe not. So we need to search for this cause. Also, we have cerebral infarction, either from the start, the infarction is associated with hemorrhagic component, as we are dealing with venous infarction, cerebral venous infarction. It's commonly associated with hemorrhagic component from the start, or we are dealing with hemorrhagic transformation for cerebral infarction. Also, we have drug-induced if the patient is using anticoagulant therapy and the patient has bleeding tendency. Sometimes brain tumor, sometimes there is hemorrhagic component inside the brain tumor, so take care from this one. Not all hematoma is a simple hematoma, may be associated with neoplastic process. So this is a scheme. So we have, once we have hematoma, maybe traumatic, maybe non-traumatic. If it is non-traumatic, search for the cause. If we are dealing with an elderly patient, we should search for these two main causes, hypertensive or cerebral amyloid angiopathy. If we are dealing with secondary causes, those are the secondary causes for non-traumatic intracerebral hematoma. This is our second. This is a young patient. As we see in this case, we have an irregular shape intracerebral hematoma. But the difference here between this case and the other case or the previous case is that this hematoma is centered or located more peripherally. It is located at the right temporoparietal region, subcortical in location. It is surrounded by hypodense vasogenic brain edema. If you see here, this edema is vasogenic, finger-like projection. Also, the hematoma exerts mass effect, as you know, effacement of the cortical sulci and the mild midline shift, and all of these features you should comment as we did before. But we have here two learning points. The first is we have different density between this one and this one. Look for the hematoma. The hematoma shows two different densities. If we measure the maximum density here, it measures about 69 Hounsfield unit, while the other side or this part measures maximum 42 Hounsfield units. So we have a difference more than 18 Hounsfield units. Anyway, once we have two different components in density in the intracerebral hematoma, it can be identified by the neck dye. This is called blend sign. Blend sign. This sign is very important because this one is a strong predictor for the growth of the hematoma. Once we have two different densities in the intracerebral hematoma, we can predict that this intracerebral hematoma can be more larger after follow-up, after 24-hour follow-up. This one is very, very important, and we should take care of this one. Also, the second learning point here is that this hematoma is present more peripherally located. It's not present in the basic ganglia. So the most common cause in this one, in young patient, may be underlying vascular malformation, like, for example, AVM. This is the most common cause. So we need to recommend to do MRI and MRE, MR angiography, searching for underlying vascular malformation. Those are the two learning points in this case. So in conclusion, or in summary, in our lecture, once we have intracerebral hematoma in an elderly patient located at the basic ganglia or brainstem, we should think for hypertensive hemorrhage. If we have peripherally located intracerebral hematoma in a young patient, most likely underlying vascular malformation. Thank you so much.